Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi.
Okey, boleh start ke? Jap. Apa ni? Jap. Ada problem sikit dengan mesin. Okey, boleh start kan?
Boleh dah.
Okey, jap ni satu mana. Okey, nampak tak? Nampak kan slides?
Nampak dah, nampak.
Jap. Nampak tak? Okey, kita mula dengan umul kitab Al-Fatihah. Okay, alhamdulillah, wassalamu ala asyrafil anbiya'i wal mursalin wa ala alihi wasallam. Okay, so hari ini saya akan present pasal neonatal infection and neonatal sepsis. So this is a lecture series, neonatal lecture series for year 5. Since you are year 5, then I expect you guys are more like a houseman rather than medical student, kan? So I'm expecting good questions come from you guys and good answers also come from you guys. So the method is actually just presentation. I'm going to present. You can stop me anytime. You can ask questions. You can even comment, give your opinions. I'm expecting a two-way communication here. Okay. So the slides is actually adapted from Dr. Said's punya previous slides, and also some information from up to date. And mainly it's actually, yeah, it's not really I mean I don't put much effort on preparing the slides because it's a last minute punya information, kan, was only informed to us the timetable I think on Friday, I think. So but anyway, that's not the reason for poor quality presentation. You can give comments at the end. Okay. So neonatal infection and neonatal sepsis. So the definition is actually a clinical syndrome characterized by signs and symptoms of infection with or without accompanying bacteremia in the first month of life. So when we say bacteremia, okay, when we say bacteremia is evidence of blood culture positive. Okay, means you yield something from the blood. And with advance in medicines nowadays, so it's not necessarily has to be culture. It can be proven by PCR, by fish, even by genetic study, or by anything. Because for example, like straps, by antigen detection in blood. So, but the keyword is bacteremia, means it's from the blood. So sepsis, with the evidence of bacteremia in the blood by any means, culture or by PCR or by antigen detection or anything. Okay, and it has to be occurred in the first month of life during neonatal period. So neonatal period defined as at birth until day 28 of life. Okay, and it can presented as septicemia, meningitis, pneumonia, arthritis, osteomyelitis, or UTI, or name it. It can be anything. Okay. And I've seen I mean, there's a lot of presentation of sepsis in neonates. I've seen a child with severe scalp osteomyelitis that's so severe that actually we have, I mean, the neurosurgeon have to remove the whole scalp. So the child got necrotizing fasciitis of the scalp. We thought we are going to lose the child, but apparently after about 2 months of antibiotic, he finally got to be discharged, but without scalp lah, because the osteomyelitis was so severe, it actually destroyed the whole might be the parietal bone, or I can't remember, occipital bone, I think. Okay, anyway, there also baby come with UTI, but this is usually with underlying metabolic disease like galactosemia or thalassemia lah. And pneumonia is very common, meningitis is also very common. So epidemiology, you can hear me well, right?
Yes.
Okay, and you can ask me any questions, just stop me, okay? Okay, we aim to finish by 1 hour 10 minutes because I've got another class then. Okay, so epidemiology is it is the commonest cause of neonatal mortality. Okay, it is responsible for about 30 to 50% of total neonatal death in developing countries. Okay, up to 20% of neonates develop sepsis and approximately 1% die, especially the late onset sepsis. And primary sepsis, which is the early onset, is 1 to 5 per 1,000 live birth, with incident much higher for very low birth weight infants. So it's actually inversely proportionate to the gestational age. So the smaller you are, the younger you are, the higher risk of morbidity and mortality from sepsis. Okay. Then, so if you see, the rate is about 15 to 19 per 1,000 live birth with early onset, and 21% for late onset. So late onset is more common, especially those who are admitted. Then 13 to 25% mortality rate, especially in premature baby. Why we are so concerned about sepsis in neonates? Because neonates, okay, they are considered a immunocompromised population. Okay, they are immunocompromised. Being a neonate itself means they are immunocompromised. So we've got lower threshold to treat, and they've got poor, complication from sepsis. Okay, clinical features, they are non-specific. They are very non-specific because when we say the immune response is poor, is included, is the whole level of immunity are actually immature, which means the first line, second line, third line are all immature. So the first line, the physical barrier are immature, especially in prem babies. They've got immature skin, corneum, what you call it? Corneum. They've got absence of corneum. I mean, the layer of the skin, which make them predisposed to infection through the skin. They also got lower gastric acid. The acid is lower in them, and they are developing their prebiotic. The gut microbiota is developing, and also an obvious reason. First of all, the inflammation, their inflammatory response are poorer, and sometimes can be exaggerated. They're immature, so sometimes they can be uncontrolled. That leads to severe inflammatory response. Sometimes it's immature in the sense of it's weak, so they cannot exert full inflammatory response, such as like fever. So recruitment of neutrophils are also quite poor. So that's why it's very rare to see infants with fever. Okay, fever is quite rare in infant, rather than hypothermia is more common. Okay, because they cannot rigors. Infants, they cannot rigors, they cannot chills, so they cannot produce fever. So that's why most of the time they develop hypothermia rather than fever. Fever in a neonates population is always a serious sign. Okay, it's more serious than hypothermia. Okay, So neonate with sepsis present with one or more of the following symptoms: hypo or hypothermia, called temperature instability, lethargy, poor cry, refusal to suck, poor perfusion. Okay, you can see the skin like mottling of the skin, hypotonia, absence of reflexes, bradytachycardia, autonomic responses, autonomic instability. So tachycardia or bradycardia, high BP, low BP, and also the last but not least is the glycemia lah. Glycemic instability also, hypo and hyperglycemia. And metabolic acidosis is not the symptoms, so it's actually an investigation. Okay, you won't get metabolic acidosis informed by the child or from monitoring, but you get metabolic acidosis from your investigation. So clinical features, there are specific features related to various systems. So it depends on the system. Okay. However, again, it's not that specific. So a child with respiratory symptoms can present with apnea or respiratory infection, or a child with meningitis can present with hypoglycemia. So it's non-specific for each system, but it gives you clues lah. Okay, for example, central nervous system, you got bulging anterior fontanelle, you got like blank stare. Sometimes you get hyper alert child, okay, high pitch cry, excess irritability, stupor coma. You can read this lah. Okay, and then cardiac. Okay, cardiac means sepsis bacteremia that leads to cardiac. You get hypotension, perfusion, and shock. So GI, feeding intolerance, vomiting, abdominal distension. Then you get hepatic, like increase in jaundice, rebound jaundice. Hepatomegaly is not that common actually as a sign and symptoms of sepsis, but it can. Okay, they can get they reduce the effect of sepsis on the liver can be overwhelming. It can actually affect the synthetic property of the liver. So they can get hypoalbuminemia, they get edema, they get hyperbilirubinemia, they get coagulopathy, bruises, and so on. Then renal, they get AKI. Okay, again, hematological could be due to marrow suppression. Their marrow are very sensitive, so infection to the marrow can actually suppress the marrow, which leads to bleeding tendency, anemia, and also low platelet. And also effect of infection to the liver can actually cause bleeding, reduction in coagulation protein factors, which is the protein synthesis. And then skin changes, multiple pustule, abscess, scleroderma, mottling, umbilical redness, and discharges. So basically, skin changes. Any skin rashes in a child, in a neonates, should alert you. Okay, you should think of sepsis in any rashes in neonates. Even though there are rashes that actually due to genetic problems, there are rashes due to just infiltration of eosinophil, like erythema toxicums, or just chemical irritation, or also allergic. But any rashes has to increase the suspicion of sepsis in neonates. So in any infant less than 28 days. So I'm going to present, I'm going to compare the early onset and late onset. So because in general, sepsis in neonates divided into early onset and late onset. Okay, this is how we differentiate them. The pathogenesis might be different, the etiology might be different, but in general, there are early onset and late onset. The management is actually different. So early onset is sepsis occur within the first 27 hours of life. However, there are some authors that actually increase the duration up to 1 week. But mainly, most people, they use the first 72 hours of life. Okay, and in severe cases, the symptoms might appear at birth, especially in infection that is perinatally acquired, okay, or antenatally acquired, transplacental infection. Kan, yang vertically vertical transmission, such as syphilis, for example, kan, the child might born with nasal snuffling, might born with rashes in syphilis, in congenital syphilis. But other infection, for example, like GBS, they usually presented slightly later, maybe after like 24 to 48 hours. But if the risk is there, I mean, if mother already had, like, for example, ruptured membrane for the past 24 hours, so the infection might already set in during the perinatal period. So by the time the child born, it's already past 24 hours of infection set in, so the child might be symptomatic at birth. Okay. If you can ask me any questions, or just stop me, because I will talk and maybe not realize I'm going too fast or too slow. So you can just stop me and ask questions. Okay, and then late onset occur after 72.
Doctor,
Okay, yes.
I'm Faris. Just want to ask, um, between early onset and late onset, just now you said that late onset are more common, right?
Late onset.
Earlier.
Late onset. Okay, late onset is more common. No, actually early onset is more common, tapi late onset is more severe.
Oh, okay.
Hmm.
Thank you.
Okay. Because the problem is late onset, the epidemiology is actually by comparing those admitted. So most of the time, we compare early onset is actually the numerator is actually all babies. Okay, but late onset, the numerator is actually babies who presented in a hospital or in KK. So that's why you get the higher percentage, 15 to 21% about there. But actually, when you compare the whole population of infant with the same age, it's actually not that common. It's less than the early onset. Faham kan? Macam complicated sikit. Tapi itulah. Okay. Faham kan? And then pathogenesis, early onset is usually vertical transmission from maternal genital tract or transplacenta. Okay. Which mean it's antenatally acquired lah. Things like treponema, syphilis, viruses, or listeria, and also candida lah. Okay. For late onset, it's divided into two: community acquired or nosocomial, hospital acquired. Okay, hospital acquired usually occurred in infant that is admitted at birth, and usually they develop after 72 hours of life. They acquired infection from surrounding the NICU environment, the organism from NICU lah. And then the community acquired is the infection that acquire after birth at home. So after discharge, they acquire infection. This is mainly viruses and also common community organism. On the presentation, early onset present with respiratory distress and pneumonia. This is the most common. Okay, while late onset, they usually presented with septicemia, pneumonia, and also meningitis. Okay, pneumonia mostly actually virus in late onset. However, septicemia and meningitis are usually bacterial in origin, and also can be virus now. So the characteristic, the risk factors. So in early onset, the risk factors are low birth weight. Okay, those premature and low birth weight infant are higher risk. And then febrile illness in the mother. So and perinatally, mother got fever, that is a risk factor. Okay, that's why any mother with fever, you have to cover the child with antibiotic. Okay. And then false smelling or meconium stain liquor. Okay, false smelling liquor, you have to think of infection lah, cholera pneumonitis. Meconium stain liquor, especially in infant that is not term, okay, or not dead. For example, like 38 weeks, 7 weeks, and even in prem is more suspicious lah.
Doktor, doktor tukar slide dah ke?
Dah tukar dah? Asal tak keluar eh?
Tak keluar. Masih dekat early onset, late onset ni.
Okay, sekejap eh. Let's just stop share. Let's just share. Okay tak? Nampak tak?
Nampak je.
Okay. So I'm presenting in table. So the table is similar lah, but the content is slightly different. So for this one, Okay, nampak kan? So risk factor, ada risk factor in early onset, rupture of membrane more than 24 hours, single unclean or more than 3 sterile vaginal examination. Okay, that's why I try to avoid vaginal examination, even though you are using sterile gloves. And then prolonged labor, okay, which is more than 24 hours, and also perinatal asphyxia. Okay, infant with perinatal asphyxia has higher risk of sepsis. And then late onset is usually the risk factor are again low birth weight, prematurity, history of admission in ICU. If I mentioned, because ICU there's a lot of bugs in ICU, so they may acquire some of the bugs and leads to sepsis, maybe even after the discharge. And then mechanical ventilation, definitely invasive procedure like intubation, UAC UVC insertion, even suction can actually introduce infection. Administration of parenteral fluid, especially TPN, and use of stock solution. Okay, use of stock solution means, for example, EBM kan, you keep the EBM and then you give the stock EBM. Then this is one of the source of infection. These are actually nosocomial, those in hospital lah. Community acquired, the most common risk factor is poor hygiene, poor cord care, bottle feeding, and prelactal feeds. Prelactal feeds means food that you give to infant prior to lactation, prior to breastfeeding. So even in Islam, we've got the rituals kan, the tahnik, where we actually give, we do tahnik. But so we do tahnik is actually the sunnah is actually at day 7. And usually most infant at day 7 they already established feeding, so there's not any issue. But since in some other cultures, for example like in India, or in Indian and some other cultures lah, the original people, for example, they do give feeding at birth. So it's not like nasi or something, tapi they give something lah at birth. Sometimes they bagi macam madu ke anything. Okay, so these are prelactal feeds. And then etiology, the early onset, the most common is GBS and E. coli. It can be one or another. So sometimes GBS is more common, sometimes E. coli is more common. But GBS is lesser now, reducing, incidence of GBS is reducing because of the intrapartum antibiotic. Okay, because we screen the mother, even though we are using HVS, despite the recommendation is actually LVS. LVS is more superior, because HVS you will miss some of the carrier lah, maternal carrier of GBS. But GBS is slightly reducing, and E. coli is the second lah, the second or the first. There are also gram-negative roads, occasionally salmonella, ada Klebsiella, things like that lah. Listeria monocytogenes, historically is not rare, it's quite common. Now also it's quite common, but because we rarely send investigation for listeria. Okay, for listeria you have to send the placenta. A lot of time we didn't send placenta. So what we do, because listeria, you can culture listeria from any fluids, any sterile fluids, from the urine, from blood, from saliva, from anything lah, from pleural effusion, from peritoneal, from ascites. But the best is actually taking the placenta swab, or in fact the best is actually send the whole placenta, or at least the insertion of the cord on the placenta for culture. Okay, and then there also early onset also can be caused by herpes simplex. These are the main virus that cause early onset sepsis. For late onset, again it can be GBS or GAS, group A straps. Then enterococcus in urine, HSV again, enterovirus, RSV and flu, pneumococcus, meningococcus, group A beta hemolytic straps, which is sama macam group A straps. Anyway, and then Haemophilus influenza, which is much rarer lah now. Okay, differential diagnosis. Sekejap, treatment. I think I missed the treatment lah. Hold on.
Doktor,
Huh?
saya baca slide Dr. Asra pasal neonatal sepsis ni kan. Lepas tu dia cakap dia kata urine culture in patient less than 24 hour is exceedingly, macam dia kata UTI in patient in less than 24 hour is exceedingly rare, so you don't need to send the urine culture lah. But then macam saya nampak tadi doktor tulis kat early onset patient can early onset patient can have juga some salmonella sepsis kan. So maksudnya saya rasa dia macam
It's not contradictory because early onset means any occurrence of sepsis less than 72 hours. So UTI at 24 hours is very rare. Maksudnya your patient got UTI at birth is very rare. Okay, that's why we don't routinely send urine FME or urine CNS at birth. But UTI can occur at 48 hours, at 72 hours, and this is when you may need to send. Okay, but again, urine is not urine culture and CNS is not a routine investigation sent for early onset sepsis, but they can get UTI. They can get UTI from early onset sepsis. In early onset sepsis, cuma they don't present at day 1. They don't present at birth.
Is there any particular reason why they don't present UTI in less than 24 hours?
Because most of the route of infection in this child is actually from mouth out, from oral. Because when they transcend down from the vaginal tract kan, from the genital tract of the mother, that's when they may aspirate or they may drink the fluid that contain the colonizer. For example, mother with E. coli, mother with GBS. So this is the route of transmission of infection. So, and in UTI in children, you know, in adult or in older children, most of the time we get sepsis, urosepsis, because of transfer of bacterial from urine to the blood. Faham tak? We get bacteremia secondary to UTI. But in neonates, it's the other way around. It's actually the blood, then UTI. Faham tak? They rarely get infection unless in late onset because of poor hygiene kan. Kalau in late onset poor hygiene, baby berak and then mother wipes from bottom to up to front, or maybe not clean enough, so they may get infection from the anal area to the urine. But in early onset, to get UTI, most of the time the UTI is actually comes from the either skin that actually migrates to the genital, or it's actually from blood that actually migrate to the urine. Okay, faham tak? And because in baby they cannot tell the sign and symptoms of UTI is very rare. I mean, you cannot tell this is UTI in kids, in neonates, but you know that it's rare, so we don't routinely take urine unless kalau you ambil investigation semua negative, tapi you highly suspicion. Contoh mother memang ada E. coli, memang ada UTI, and then ada Proteus mirabilis. You know, these are organisms that commonly cause UTI kan. Then you may take the urine, but urine culture is not a routine in early onset sepsis. But for late onset sepsis, you have to take urine. It's part of the septic workup. Especially kalau patient tu ada macam prolonged jaundice, ada vomiting, ada fever, then you have to take the urine. Faham tak? No?
Faham doktor, thank you.
Okay, faham kan?
Sorry, Dr. Alwi. For the etiology just now, I can see that there is a bacteria and virus. So for fungal etiology, it is considered rare in neonates as well.
Fungal biasanya untuk term jarang, tapi in prem you have to consider fungal infection in prem. Okay, as in early onset sepsis, fungal usually they don't get early onset sepsis due to fungal unless the mother get very severe fungal colonization, candida colonization, down there kan, and not treated at all, then they may have fungal infection, because we know fungal they can actually migrate and can infect baby transplacentally. But the symptoms and signs are very difficult to elicit lah for fungal infection. But in late onset sepsis, it's very common. It's much more common in late onset sepsis. I think I tak letak kat sini. Especially in preterm infant. Okay, preterm infant who receive multiple broad spectrum antibiotic or multiple course of antibiotics, those with NEC, with underlying liver problem, AKI or liver problems, these are the infants that has higher risk of candida, of fungal infection. That's why in prem baby, there are evidence saying that prophylaxis, actually there's meta-analysis produced in 2019, 2018 good. There's evidence saying that prophylactic antifungal, systematic antifungal is advocates in preterm infant less than extremely low birth weight infants, less than 1 kilo. So this infant, we usually give prophylactic systemic antifungal such as nystatin, oral nystatin, or oral fluconazole as prophylactically, because they have very high risk of getting candida lah. But that is in late onset. In early onset, it's not common. It's quite rare. Okay.
Thank you, Doctor.
Differential diagnosis.
Doctor, I have a question. What about torches?
Torches. Okay,
Is it common?
Okay, torches is antenatal infection. You have to remember this sepsis. When we are talking about sepsis, our main concern is actually perinatally acquired infection. It's not antenatally acquired infection. We know some infection they can actually occur antenatally. For example, chickenpox kan. Chickenpox can occur antenatally. Okay. For example, if a mother got chickenpox at first trimester, the child may actually born with a complication of congenital chickenpox. So loss of limb, microcephaly, loss of limb, heart problem. For example, like rubella kan, congenital rubella syndrome. These are actually antenatally acquired infection. They rarely present with sepsis. They don't present with sepsis. You know, there's a definition for sepsis kan. These are the definition kan. They don't present with this definition, but they present with the consequence of the antenatal infection. So do torches. Torches is antenatal infection. Okay, and the risk is actually higher if the mother acquired the infection at the third trimester, at the highest. Okay, however, if the mother I'm going to use a lot of term yang kalau you tak faham, you just ask. If the mother seroconverts, okay, or the mother had infection in first trimester, the child can also get, but less risk compared to infection at third trimester, because you have to understand the development of your placenta, because this infection they infected the child. The transmission is actually through placenta, via transplacental transmission, which mean they need to find a breakdown in the placenta to enter the child. You faham? And at third trimester only, the placenta is breaking apart. So after third trimester, you will see I can't remember the name of the structure of the placenta, but the trophoblast. The trophoblast is actually wider apart, and you start to get this breakdown of placenta, detachment of placenta at third trimester. I mean towards term. So this is the route of entry of organism. Okay, faham tak? Tapi if you get the infection at early on, for example, mother got torches during first trimester, they are less likely to infect the child because they less likely to penetrate the placenta. Okay, faham kan? So torches, they don't cause sepsis if acquired antenatally. However, okay, you can get torches perinatal or postnatally, but they will present as late onset sepsis. Okay, faham tak? But bear in mind, okay, torches, a lot of us, we got torches already, tapi kita tak tahu pun kita pernah affected by torches. I will bet if we take the IgG torches kan, if you do serology for torches in all of us, at least 60 to 70% of us already got toxoplasma, IgG, all these torches lah, rubella kita lah because we are immunized kan. Tapi toxoplasma, CMV, most of us are actually positive. We got the IgG. Tapi because torches infection postnatally, I mean after the neonatal period, usually is asymptomatic. Okay, we don't know. Okay, faham tak? So, tapi dia boleh jadi dekat late onset. Okay, postnatally they can acquire torches from surrounding. For example, maybe kan mak yang kerja awal, okay, lahir beranak, dia tak jaga anak dia, hantar pergi nursery. Okay, nursery is a source of CMV infection lah, especially. Okay, because dia transmit through urine lah, urine. Poor hygiene is it's not fecal oral tapi dia poor hygiene, transmit from urine. So it's fecal oral and also from urine and also bloodborne juga. So for example, you send your child maybe like 10 days old, 15 days old, send to daycare or you yourself have another older children like 2-3 years old who are still on diapers, who get CMV infection from elsewhere, and then you wash them, okay, and you don't properly wash your hand, and then you cater your baby, newborn baby. Then this is one of the way they get infected by CMV. But again, CMV, they don't usually cause sepsis. Okay, faham tak?
Faham?
Okay, good. So differential diagnosis, I missed this one. But differential diagnosis is a lot because the definition is very broad. Okay, basically the definition is very broad. Look at the definition. Clinical syndrome characterized by signs and symptoms of infection. What are the signs and symptoms? These are the signs and symptoms. Hypothermia, hypoglycemia, hyperglycemia. So it's very vague. So the differential is very vague. For example, if the child lethargic, so it can be caused by IEM kan, can be caused by hypoglycemia, for example, or hypocalcemia, or hypomagnesemia. Poor feeding also can be caused by hypoglycemia, hypomagnesemia, electrolyte imbalance. It can be caused by IEM, especially after you start feeding, the child look septic looking, look lethargic, become jaundice. It can be because of tyrosinemia, galactosemia, or it can be caused by urea cycle defects, or it can be even genetic problems. You know, baby looks hypotonia, after a while look hypotonia, absence of neonatal reflex. Might as well, you may know this child got SMA, or any neurological problems, even stroke. Okay, faham kan? So the differential diagnosis is a lot. Okay, however, any child presented with any sign and symptoms of sepsis, or even any child with a risk of sepsis, you have to start antibiotic, either empirically or after suspicion, after clinical suspicion. Empiric means prophylactic, sort of prophylactically lah. So investigation is blood culture. This is a gold standard. As I mentioned, it has to be bacteremia tau. However, blood culture in neonates, the positive culture is only about 30%, but more than compared to in older children. Then other septic screening like total leukocyte count, absolute neutrophil count, immature to total neutrophil ratio, and CRP. These are parameters that can give you clues, okay, on whether the child got sepsis or not. Then lumbar puncture, we don't routinely use lumbar puncture in early onset. As I've told you, usually the infection, the root of infection is actually from oral, kan? From oral. So it takes some time before they can penetrate your meninges and causing meningitis. Then, but in LOS, all infant with LOS should undertake lumbar puncture. Okay, should, sepatutnya lah. However, we can postpone if patient is critically sick, or we can identify the source. For example, patient yang datang dengan fever and then noted tachypnea, so actually memang ada pneumonia, then we can abandon LP lah. Tapi kalau patient datang dengan fever at day 10 of life, day 15 of life, after 72 hours of life, you have to do LP sepatutnya. So analysis of lumbar puncture, we look at the cell, the CSF protein, glucose, and also the ratio lah, CSF and blood glucose. So these are the results. I'm not going to touch on the LP lah. Okay, bloody tap. Again, because I'm not going to touch this, but just mention it lah. Because sometimes you can get bloody tap. Bloody tap can be a sign of infection as well. For example, as infection like such as herpes kan, they can cause xanthochromia. So which mean there'll be blood in your bloody tap, but it's not actually due to blood. It's actually due to infection by herpes. But most time it's actually traumatic tap. Okay. Investigation urine culture. Again, have low yield and not indicated routinely. Tapi kalau dia ada risk of fungal infection, especially patient with underlying urogenital malformation, visco. So you have to know which infant that you have to suspect got all this abnormal anomaly lah, the urogenital anomaly. For example, baby with oligohydroamnions, or baby with single umbilical vein, okay, baby with SGA, abnormal Doppler, abnormal what you call it, umbilical Doppler antenatally. So these are the patient with high risk, where you can actually start with, you can do bedside ultrasound of the kidney, and if you noted there's abnormality, then you may have to take urine culture. Okay. And also baby with neuromuscular problems and baby with neurological problems, spine problems, infant of diabetic mother, these are the baby with higher risk of urine infection. Okay, radiologically, definitely you need to do at least chest X-ray in infant presented with sepsis, and abdominal X-ray kalau ada abdominal signs lah. Okay, cranial ultrasound and CT if you suspect meningitis. Supportive, again, management is mainly supportive. Maintain the thermonuclear environment, ventilation, oxygenation, saturation, the sugar glycemic control should be monitored lah. Glycemia should be monitored, because we know hypoglycemia and hyperglycemia can cause poor prognosis. And then the volume, the hemodynamic stability of the child has to be maintained. You may need to give boluses of fluids and even inotropes. Okay, and also PEG cell, because in neonates, all the organs are very susceptible to sepsis, even the marrow kan. So if you got any bacteremia, can actually suppress the marrow. So they may need to be supported using PEG cell, FFP, and so on, and even platelet. Okay. Antimicrobial therapy, okay, there's no single recommendation. It's based on your antibiotic stewardness and antibiotic protocol of the hospital. Definitely in ICU, they monitor the organism in the ICU, and we usually recycle the antibiotic every 6 monthly or yearly to prevent development of resistance. But in general, okay, in units, okay, in any antibiotic treatment, we try to use the narrowmost spectrum antibiotic. Okay, especially in early onset antibiotic, we have to cover the most common, which is the gram-negative GBS kan, the most common GBS, the gram-positive, and then the most common gram-negative, which is the E. coli. So you have to give antibiotic that's cover this both strain. Okay, that's why most of center we use penicillin base, which is either C-pen or ampicillin or amoxicillin even, and then to cover narrow spectrum antibiotic that cover the gram-positive, and then we also got narrow spectrum antibiotic that covers the gram-negative, which is the aminoglycosides. So most of the time, in most center, they will use 2 antibiotics, which is the C-pen and also penicillin and also the gentamicin. Okay, this is for early onset sepsis. For late onset sepsis, especially those nosocomial, we know the organism is actually caused by the hospital acquired kan, by the hospital organism, by the ICU organism, and this organism has been exposed to the first line, and most of them are resistant to the first line, there's penicillin and also the gentamicin. That's why we use a broader spectrum because you got broader range of organism and organism with high resistant profile. So we use a broader spectrum, a stronger antibiotic. Okay, most of the time we do combine antibiotic, a broader spectrum that covers gram positive and a broader spectrum that covers mainly gram negative. Okay, most of the time we use things like tazocin, amikacin, or a lot of center, even our center, I think we use cefotaxime and amikacin. No, we don't use. I think we use cefotaxime and amikacin, or cefotaxime and CPAN. It doesn't matter. I mean, it helps to the center lah. Okay. The duration also depending. Nanti I give. Okay, this is the duration lah.
Dr. Alwi, regarding the choice of antibiotic, macam we give yang narrow spectrum. So kita tak risau about example beta-lactamase ke, we don't give clavulanic acid and so on.
Okay, you have to understand, kalau EOS kan, kalau early onset, we know that the infection comes from the mother kan. And we know the most common is GBS and also E. coli. And this organism, the community organism, because EOS are actually community acquired. Remember, EOS, early onset sepsis, are community acquired. Okay, because they are community acquired and we know the strain, the pattern of strain in the community, we know the most of the penicillin and most of the straps and gram-positive organisms still in community still sensitive to penicillin group. So we give the most common lah, because this is what we call empirical kan. This is all actually empirical antibiotic. The antibiotic that we think will work most of the time. And for the gram-negative, we know ESBL in community is very rare because we don't use gram-negative, broad-spectrum gram-negative macam cefotaxime or the third generation of cephalosporin. We don't use it in community because these are all IV formulation kan. So we don't use them in community. So we know organism in community are mainly sensitive strain. Okay, so you can give a narrow spectrum gentamicin that most of them works for gram-negative. However, if you know the mother, for example, mother UTI and receive multiple course of antibiotic during antenatally and the culture grow, that's why we need to take culture of mother. Kalau mother datang infection, take culture. Kalau datang urine, take urine culture. Take HBS. Take the blood even kalau mother datang sepsis or bacteremia. So you have to identify the culture. Okay, if you know the mother is carrying a multi-resistant organism, for example UTI, E. coli, ESBL kan, then we have to treat the child accordingly lah. Faham tak? That's why history is very important. Kalau mother got history of, it's not sufficient by saying, oh mother got risk of sepsis because the child got risk of sepsis because mother got UTI. That is not sufficient. We want to know the culture, the sensitivity. So you will decide based on that. Okay, faham tak? Okay. And contoh mother yang memang ada, contoh mother yang ada IE for example, you will come across mother with IE, infectious endocarditis, and then you culture and you grow Hacek, for example, Hacek or Streptococcus viridans, and you can determine the sensitivity. So you can give the antibiotic, first line antibiotic for this early onset sepsis in the child can be based on the mother punya sensitivity lah. Okay, the duration.
Maksudnya yang beta-lactamase bacteria pun dia uncommon lah untuk ni, untuk golongan-golongan yang
untuk early onset is uncommon. Okay. Untuk late onset is very common. Because the onset macam I mentioned, especially kalau dia dah admitted dekat ICU, so they've got infection from the ICU organism kan, yang dah develop ESBL. Okay. So you bagi tu lah. That's why in the first line of empirical antibiotic for late onset is actually those that can cover the organism lah, the multi-resistant organism. For example kan, contoh lah, you tahu dekat ICU sekarang ni ada outbreak Stenotophomonas. Okay, you tahu Stenotophomonas, they are inherently resistant to carbapenem group kan. So you tak boleh lah bagi dia meropenem or imipenem. So you kena bagi dia, you kena start benda lain lah, contoh macam amikacin ataupun you start dengan Bactrim macam tu lah. Okay, okay, next. So these are the duration, meningitis, blood CNS positive meningitis without meningitis, and probable sepsis is 5 to 7 days. But usually, if blood CNS positive without meningitis but blood CNS positive, if it is gram positive, sometimes we go to up to 7 days. Tapi kalau gram negative, if gram negative organism, we have to prolong to 14 days and we have to do LP. Okay, indication for starting antibiotic. So in early onset, okay, these are the list of sepsis. Okay, so when you diagnose a child with sepsis, there are different diagnoses. You can either diagnose them as presumed sepsis because of presence of risk. Okay, so for example like this kan, if the child is well, tapi dia ada more than 3 risk factors for early onset sepsis, then you can treat the child with empirical antibiotic with the diagnosis of presumed sepsis. Faham tak? Tapi kalau the presence of false smelling like quar or presence of and a positive septic screen, kan, macam ni B and C, we don't call it presumed sepsis. We call it probable sepsis or clinical sepsis. Faham? So the duration will be different. Okay, when you presume something, once you got the evidence, you have to find evidence against it. Okay, so but when you treat something because of high probability, then you have to be committed with the treatment. Okay, faham tak?
Doktor, positive septic screen tu maksudnya
macam I mention tadi, CRP,
okay.
Dr. White dia high, absolute neutrophil count dia high, atau low platelet, low Dr. White, things like that lah. So ada something positive septic screen. Kalau ada culture, then once ada culture, then this is a confirmed antibiotic, so you kena follow this one lah. You kena follow this table. Kalau probable is 5 to 7 days. Kalau presumed sepsis, 24 hours sometimes is sufficient. Because it's based on risk factor, so you just give at least 24 hours antibiotic and you reassess. Okay. Because in general, any sepsis, usually it will last, a confirmed sepsis, usually it won't recover within 24 hours. Okay. So LOS, you need to have, if you've got positive screening and then strong clinical suspicion, then you need to start antibiotic. So as I mentioned, empirical antibiotic, like I've mentioned just now, either the two narrow spectrum covering gram negative and gram positive in early onset, or broader antibiotic that cover the multi-resistant organism. For late onset sepsis, prophylactic antibiotics, we don't give prophylactic antibiotics, and except in some condition. For example, a child who underwent invasive procedure. Okay, for example, you've got a child, you try to insert a central line, multiple attempt, multiple poking, and there's a lot of redness, then you may start prophylactic vancomycin just to cover for Strep epididymis or Strep epididymis ataupun cons, ataupun to cover for any MRSA lah, Staph aureus yang ada dekat kulit. Okay. Or for instance, macam I mentioned tadi, extremely prem infant, you're actually encouraged to start prophylactic systemic oral antifungal, especially if you anticipate patient on TPN, patient on broad spectrum antibiotic. So this opportunistic organism has to be covered. Management is more mainly supportive. Okay, for meningitis, the mainstream of treatment is third generation cephalosporin, because it has good penetration to the through the blood-brain barrier. However, bear in mind, third generation cephalosporin is a good ESBL inducer. So if you use a lot of cephalosporin, then you should expect there'll be a lot of ESBL. Okay, and once they got ESBL, then you can use the cephalosporin. So you need to use other antibiotics, especially the other beta-lactamase like the meropenem, the carbapenem group. Okay. See, at least recent report said 60 to 70% of gram-negative are resistant to cephalosporin, because cephalosporin abuse is actually one of the main cause of emergence of multi-resistant organism. blah 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 ni bosan. Okay. Okay, again, this is, I've mentioned this. Okay, if you suspect, if patient got central line and you suspect it is actually CLABSI or CRBSI, which is catheter-related bloodstream infection or catheter-linked bloodstream infection, then you have to start vancomycin. Okay, so the antibiotic is not something that is fixed, so it depends on the situation. Even if you highly suspect this to be candida or fungal, you can actually start the baby with antifungal rather than antibiotic. Or if you suspect this is a virus due to like recent URTI in your nursery, or maybe ada parents yang ada URTI masuk and then parents memang confirm ada RSV ke, for example, then you can actually start antiviral earlier lah. Okay, contoh you suspect herpes because of ada herpes manifestation kan, ada SEM disease, nanti I think there's in the slide herpes. So maybe you can start the acyclovir earlier. So patient memang you suspect ada chickenpox, then you start acyclovir earlier. So CMV kan cyclovir dan sebagainya lah. Okay.
Tapi doktor, yang in that case macam kita suspect more towards viral or fungal infection, kita akan start antiviral dengan ataupun antifungal lah. Tapi
dia
for
kena cover kan antibiotik.
kita still bagi juga antibiotik yang empirical tu lah.
Yes,
Okay,
yes.
okay.
Yes.
Right. Thank you.
Unless kalau you memang confirm dah, oh ni memang chickenpox, then kita tak bagilah. Kita bagi acyclovir. Once you confirm, then you can stop the antibiotic. But the meaning of empirical is you give antibiotic without evidence.
Okay. Macam contoh yang doktor bagi earlier, yang contoh mak dia ada candida vaginitis yang teruk betul. Lepas tu anak dia ada sepsis tu, so kita start antifungal, antibiotik pun kita bagi juga.
Kita bagi tak? Yes. Antibiotik masih bagi.
Okay, thank you doktor.
Okay, aminoglycosides, ini tak yang ini sana. Yang ni boleh baca kot. Okay, management, reserve antibiotics. Okay. Sana. Okay, how about herpes? Again, herpes is very common. The complication is dangerous. Okay, so usually they presented with neurological manifestation, but they can present in 3 ways. Usually they can present in 3 ways. Okay, they can present in 3 types. They got SAM, the skin, eye, and mucous membrane disease. Okay, so they can get blister around the eye, around the skin, around the mouth. You know, like herpes infection, typical herpes infection in adult. Or they can get isolated CNS, which means sometimes they can present it with lethargic, meningitis-like or encephalitis-like symptoms of fever, meningitis. So you have to have suspicion of HSV, and sometimes they can get disseminated. Okay, this is the worst lah. They can got skin, they can got liver impairment, kidney impairment. They've got overt like meningitis features. This is the worst. They got very high mortality lah. Okay, so any suspicion you have to start acyclovir as soon as possible. Okay. The same disease can be very early. Sometimes you can ask the mother, is there any genital lesion kan? Genital lesion, or the mother has any herpes features, rashes ke? So the child may acquire it during perinatal lah, during waktu delivery. Usually the one that get the disease during delivery, they presented with CNS, isolated CNS or disseminated, which is after 1 week. But the one presented very early, they acquired very early lah infection. So these are like herpes infection. Look at the mouth kan, baby punya mouth. Okay, ni malah pasal ni. Okay, just remember this. Okay, HSV is very difficult to diagnose. Most of the time we do LP and then we send for herpes PCR. But again, it's not specific. It's specific but not sensitive to rule out HSV. Oh, malah. Okay. Bosan. Imaging, okay, bosan. Okay, ada infection like I mentioned, the torches, the chickenpox. This also can cause sepsis in units. Okay, I think that's all. Any questions?
Doctor, sorry, I have 3 questions. Tapi simple je kot. First question is regarding chest X-ray. Because patient usually neonate kan, mungkin dia ada distress syndrome dan sebagainya. So it's quite difficult untuk kita tengok chest X-ray to say that dia ada pneumonia ke tak. So actually, how do we approach chest X-ray?
Oh, that's very difficult question. A simple one. I'm not sure. Frankly speaking, I'm not sure. If you show us chest X-ray to 3 neonatologists, I bet 3 of them will give different answer.
Okay.
So the best person is actually speak to your radiologist and correlates clinically. But before you do that, start antibiotic.
Alright.
Start antibiotic and then you confirm your diagnosis. Okay, lagi?
Another one is regarding high pitch cry. Actually, I try to search what are the reason behind high pitch cry in neurological punya in baby.
Kalau it depends on the cause. Kalau bilirubin, kalau connectirius kan, kalau bilirubin induced neonatal neurological disability atau connectirius, the causes is actually because deposition of bilirubin on the vocal cord. Okay, that cause the high pitch. Okay, but in meningitis, the high pitch cry is actually I'm not sure why. If I'm not mistaken, the infection dekat basal ganglia or something that cause the high pitch cry. Tapi but if I not the last time I've read about this is actually waktu I first year, I think 2016. And that time the answer is not certain. They're not sure, but I think it's something to do with basal ganglia or something.
So
You check.
Is it is not objective lah doktor kan? Sebenarnya subjective to mothers rasa dia macam high pitch ke?
No, usually kita yang akan dengar. Doktor yang akan decide. Mother, they won't come with high pitch cry. They won't come with complaint of high pitch cry. High pitch cry is actually a sign. It's not a symptoms.
Alright.
Okay. Usually, but after a while you know lah high pitch cry. I heard high pitch cry.
Alright.
Okay.
Yeah, thank you.
Lagi kata 3.
Another one tu buat cycling antibiotic. So tapi saya rasa actually can you explain about cycling antibiotics tu in ICU?
Okay, biasanya in ICU kan kita buat macam okay, di 6 month kita akan guna tazobamicin. Our phonosocomial infection and also second line lah. Okay, after that after 6 month kita akan tukar. Kita akan guna cefotaxime, cefosipan. Okay, for 6 months. And then kita tukar pula. Okay, kita guna cefepime. Okay, lepas tu kita tukar balik tazobamicin. So usually after 6 months or 1 year kita akan recycle. So kita tak nak the organism in the hospital develop resistance.
So, antibiotik tu maksudnya nanti next month kita akan the first line antibiotik kita akan bagi pada patient ialah another antibiotics. But it's still broad spectrum.
Biasanya first line kita tak tukar, kita tukar second line.
Okay.
Antibiotik for nosocomial infection atau antibiotik for late onset sepsis. Ataupun second line tak works with first line, then kita tukar second line. Second line yang kita cycle.
Thank you.
Dr. Alwi, because I want to ask, because the approach for sepsis in neonatal sepsis and adult is different, which is kalau adult dia ada scoring, example like QSOFA score and so on. Tapi kalau yang kiranya yang bukan neonates tapi dia still pediatric, contoh yang lebih daripada 1 month old example, so how we approach it based on like adult ke ataupun macam ni juga, macam kita?
Okay, actually kita ada sepsis bundle kan, kita ada sepsis bundle. I think the latest 2019 is sepsis bundle. Pediatric sepsis bundle pun dah establish. Cuma problem with sepsis bundle kan, again in young infant, biasa less than 3 months old, we always start with empirical antibiotic. Kita akan guna macam neonates. We've got lower threshold. So problem dia, especially the first 3 months of life lah, they cannot produce the inflammatory response. But a lot of sepsis bundle, they based on CIRS tau, they based on inflammatory response punya criteria. And these neonates, we know they cannot exert the respiratory response, inflammatory response. So it's not applicable for very young infant, less than 3 months old lah usually. Tapi in older infant, we can use that. So for example, patient datang dengan tachycardia, we're not necessarily going to start antibiotic kan. Contoh budak 5 tahun datang dengan tachycardia. Are we going to start antibiotic? No, we're not. We have to investigate other thing first, then only after everything come back, we may consider antibiotic. Okay. Tapi there's a lot of other causes. But in this small infant, because they cannot complain now, they cannot complain. They cannot complain and they cannot produce the signs and symptoms. So we have to do, you cannot use this same approach like adult or older children to decide whether this is sepsis or not. Faham?
Okay, faham Doktor. And then earlier on your slide ada mention about gasping respiration. Yang tu how to we know that it's gasping respiration ke ataupun it's just a periodic breathing ke?
Kalau periodic breathing lain, periodic breathing is normal breathing, cuma nampak laju, occasionally laju and then slow. Gasping is gasping lah. Gasping macam orang gasping macam deep breath in. Macam tu. Gasping lah, macam orang nak mati tu lah.
Alright.
Gasping is not tachypneic. Okay. So that's very specific. Tapi actually in neonates, it's more often rather than gasping, it's actually apnea lah rather than gasping. Or bradypnea or apnea.
Alright, thank you.
Okay, soalan. Ada soalan?
Dah tak ada kot Doktor.
Okay. So in general, the take-home message is you need to have very high suspicions of sepsis in neonates. Okay, always start with antibiotic. You should have very low threshold to start antibiotic. Anyone you're not sure, start the antibiotic. Okay, because the last thing you want to do is delay antibiotic and cause patient to die. Because in neonates, once there is sepsis set in, they may not be able to compensate for long. So a lot of them succumb to death, and it's very detrimental to see neonatal death. Okay, even though it's very common compared to children death, neonatal death is very common. Kalau kita punya mortality meeting back in USM, mortality meeting, monthly mortality meeting, kalau ada 10 death, usually 9 or 8 neonates. And a lot of them are actually caused by sepsis. Okay, itu cukup. So kita boleh tanggung dengan tasbih kafarah dan suatu mas. Okay, assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Thank you Doktor.